This level of care, clinical focus. So clinical focus starts to get more technical. So the clinical focus is really supposed to be about the primary diagnosis or the underlying cause for the functional impairment that your child is experiencing. As clinicians, we typically talk about a clinical formulation, which is supposed to be at the end of any diagnostic assessment, which is a description of what causes and sustains the primary diagnosis, or whatever the core concern is, that presenting problem, people typically call it, that someone shows up with. There is a legal standard associated with this. This is very recent. This was a court decision in a case called Witt versus United Behavioral Health. You might be familiar with UBH. And what the judge found there is that it's a generally accepted standard of care that effective treatment requires treatment of the individual's underlying condition and is not limited to the alleviation of the individual's current symptoms. And what that means is that the focus of care should be on addressing the things that cause these symptoms to keep recurring. It's not just enough to say, well, we address those symptoms. We need to be able to say, we address the things that cause the symptoms. And that is really critical, because there are all sorts of ways in which you could manage to reduce a particular symptom. But if you're not addressing the cause of it, then long-term, you're really not much better than when you started, right? And so what we really are saying is, well, what's the way to address this core issue that's creating these symptoms, right? So how are we addressing depression, or how are we addressing anxiety that's being manifested in all these different ways? And the Federation of Families has posted a workbook that I believe the National Federation put together, and then that Idaho has done some work customizing for Idaho. Is that the right characterization? I want to make sure we're giving credit where credit is due. So they have a family and youth workbook, which is really a terrific piece of work. And as you're going through there on the family version of that on page 7, it asked about diagnoses that you have been provided for your child, who provided it, when it was provided, those sorts of things. The diagnosis is a good starting point for thinking about what your clinical focus is. What is it that you're really going to hone in on as you're working together? On the completed CANs, it identifies what the primary mental health diagnosis is, and if there are any other secondary or tertiary diagnoses that would also be addressed. So you should be able to see the most current primary diagnosis that they're using to authorize services right there on the CANs. The CANs is not a diagnostic instrument, so the CANs is not asking about a series of symptoms that would then produce a diagnosis for folks, but your CANs ratings should be consistent with the diagnosis that's being provided. So what does that mean? Well, if you look at the definition of the CANs items, and what I've done here on the left-hand side is pull out all the CANs items from the behavioral and emotional needs section, and that's the section that has items that relate to diagnostic categories or potential diagnoses on the CANs. Anytime something is a 2 or a 3 in terms of an item on that section, then it likely should be associated with a similar diagnosis. So for instance, the adjustment to trauma item, if that's rated a 2 or a 3, then you might expect that a primary or secondary or tertiary diagnosis would be post-traumatic stress disorder or something in that family of disorders. And then this just walks through kind of each one of those items and crosswalks them for you with what it looks like is the diagnosis or set of diagnoses that might be there in the DSM-5, right? So for instance, if there was a 2 or a 3 on psychosis or thought disorder on the CANS, then you would look to see if there was a diagnosis of something on the schizophrenia spectrum or any other psychotic or thought disorders from the DSM-5. If there's an attention or concentration rating of 2 or 3, then you might look to see if there's a primary or secondary or tertiary diagnosis of attention deficit hyperactivity disorder. Also, impulsivity might include an ADHD diagnosis, but you might also look at mania or impulse control disorders, and they may be your primary diagnoses. So this just walks through or crosswalks what CANS items might be associated with different diagnoses. If you have a primary diagnosis and yet the CANS item that would seem to be associated with it is not rated a 2 or a 3, then that should be a bit of a red light to you. You should be asking the clinician, well, why wasn't this rated a 2 or a 3 on the CANS, right? Because they might not be linking together what that assessment found and what their diagnosis is. And that's a bit of a problem. In fact, part of the reason that could be a problem is if they're underrating the CANS items, then you're not likely to qualify for the appropriate level of care that you should be receiving, right? So you want to make sure that those things line up. All right. All right, and you can see these crosswalks here that continue. And don't worry about writing these things down because you can get a copy of this. But almost all of these CANS items crosswalk pretty easily and have pretty similar names to the diagnoses that might be associated with